All right. Welcome, everyone, to the N3C Community Forum. My name is Srita Rajpate. I'll be stepping in for Joel Saltz today. I also work at Stony Brook Medicine. I am a family and preventive medicine clinician as well as informaticist. So I'm excited to be here with all of you today. Next slide, please. So this presentation will be recorded and archived on our CD2H YouTube channels. Please keep that in mind. We welcome you to use the Q&A button to post any questions you have. You can also use the raise your hand feature, and I'll be monitoring the chat section as well for any questions that are posted there. Next slide, please. So upcoming presentations. So next week, around the 31st, we'll have Term Hub concept set comparison analysis and authoring, as well as CMS data in N3C by Siegfried Gold and Sean O'Neill and Tom Richards. Our November 7th meeting has been canceled. November 14th, we'll be discussing the impact of COVID-19 on clinical outcomes among acute myocardial infarction patients undergoing early invasive treatment strategy. This will be by Sula Mazimba. Our November 21st meeting is canceled for the Thanksgiving holiday. And on November 28th, we'll be talking about HIV, COVID, and social determinants of health, leveraging N3 resources for an R01, and we'll have a panel of speakers on that day. Next slide, please. So our N3C data enclave is provided by 76 sites. We have about 19.4 billion total rows with approximately 6 million COVID positive cases. Next slide. Thank you. So today we will be hearing from Jim Phuong. Hopefully I said that correctly. He'll be speaking with us about extracting patient-level social determinants of health into OMOP common data model. So Jim, I'll have you take it from here. Thank you.
All right. Can you see the screen?
Yes.
Okay, and I'm going to go into slide deck mode. Is it showing?
Perfect.
Okay. All right, cool. Thanks for the introduction, Shrita. So my name's Jim Phuong. I'm a research data scientist at University of Washington. And I have also helped co-lead the N3C Social Determinants of Health domain team for the last, I guess, 3 years since the inception of N3C. Today, I'll talk about what we've learned from the extraction and sort of the data representation of patient-level social determinants of health, and really how does the data get into OMOP common data model. The objective of today's talk is to discuss patient-level social determinants of health, consider the different abstract formats in which social determinants of health may be collected and stored, how that gets processed, and the considerations needed in order to transform that into a research data set. And towards a bigger picture, how does data quality assessment need to be considered for this type of information? And also, what's the social determinants of health data life cycle from health system to research data set? And kind of what does that look like? Although the name of this talk is actually extracting patient-level social determinants of health into OMOP common data model, this is actually the first of 2 papers that are actually represented within this talk. And my short keyword, I guess, for each of these papers is that the first paper is focusing on a direct route in which patient-level social determinants of health might get from an electronic health record to an OMOP common data model. The second one, advancing interoperability of patient-level social determinants of health to support COVID-19 research, is the indirect route, where the data might get transformed into a common data model like I2B2 and Trinetics, and through several levels of translation, it eventually reaches OMOP. So So I guess let's start this off with just describing what are patient level social determinants of health. What is that phrase? And I'll often point people to this paper by Samuels, Callow, and Al. The high-level phrase is that social determinants of health is the non-clinical factors in which people live, grow, learn, and it's a lot of the factors which keep people healthy outside of the interactions with the health system. And oftentimes terms might get separated into social risk factors or social needs. And generally there's certain contexts in which if you're asking about social needs, you're asking about basic needs. And then when you ask questions about that, it's in a questionnaire or some format like that, it might be certain categorical representations of a person's social determinants. They sort of fit into a bigger picture. Social determinants of health is one of the three trifecta within the population health framework. And at the beginning of COVID, we were asking these questions about COVID risk and are there differences based on where people live and how people live that might change their risk of getting COVID or getting severe COVID. So I have used this slide before and I like to come back to this from time to time because this really shows the thought of what is the social determinants of health having its own representation, what are demographics playing a certain risk factor role, and what's the role of policies. So social determinants is one factor and it could be collected in some number of ways, but in context, it's part of looking at outcomes and it's also looking at the interventional role of policies. At one point, we were trying to use information that is available on social determinants of health. And generally, these are place-based metrics that one might start with before getting into patient-level data. And so this is a paper that was published by Cherise Madlock earlier this year. That's the community-level social determinants of health. And we were trying to integrate that data from census-based data sets and social deprivation index. And there's a number of data sets involved into this. But we were looking at this from the social ecological model. So can we separate some of these factors as patient individual level, or the interpersonal level, organization or community level, or are they actually policy and societal level factors? So depending on that, you might take an interpretation of those variables in a very different way, considering that it might be an individual level or an aggregate. And earlier this year, we had also published a paper that was looking at societal level and community level and individual level, and how does social determinants of health how should that be considered with regards to, say, the genetic factors and the biological factors about either the virus or patient biology. So we actually separated a lot of these factors, which might be considered social determinants in a very broad stroke, into individual and community and system levels, as well as the kind of social cultural aspect or physical built environment aspect that they represent. Okay, now that being said, I'll get into the first paper. So this is the direct route of how patient level social determinants of health might get captured and then translated or transcribed into an OMOP common data model. This paper, as well as this graphic, was sort of a testament to why it's really necessary to involve a community and a team of diverse researchers focusing on social determinants. And this graphic here is actually a simplification. I'll show you what it actually looked like when it was originally created. But we were working backwards, actually. We knew that in the community at large, certain health systems have had a longer history with capturing patient-level social determinants. And that's contributed a lot of the creation of screening tools and even the vocabulary for what kind of social determinants, what social needs might be captured within what survey tool. And we were looking at OCHIN, Oregon Community Health Information Network, as sort of like our, frame of comparison, because that health system, that or information network, they have had a longer history with use of Prepare and Thrive screeners. But in order to consider how do we get our data to be even comparable to say OCHIN, we worked backwards into thinking, this is actually where the data is coming from each site. And then from that, that site is actually transporting their information from their EHR and potentially from their flow sheet records, where a lot of the screening tools are captured. And then even earlier than that, it's looking at the clinical workflow. So if a health system is not using these tools, or they don't have a clinical workflow for this, we're not likely to see this entire flow. But it was, this is where you can kind of section off, like, this is how it gets generated, this is how it gets transcribed, and then it continues to flow eventually into N3C. Now, originally, it was a back and forth email. There was something like 17 or 18 emails to sort of describe this problem. And the best way that I knew was to digest all of that information was actually just draw a picture based on what was talked about. And this has continued to evolve, but a lot of the things that we were talking about was about a certain phase, like clinical encounter, where the data was being collected from patients or transcribed by a medical assistant. And then, there's bridging, a lot of bridging steps here, where there could be some data that might be mistranscribed, or it might just not flow because of issues in the harmonization step, or the, mapping considerations that are a little bit more nuanced between vocabulary to vocabulary. So much of this is actually, we started off with like all these assessment items, design items, and considerations. And we sort of quickly knew that there are some things that we potentially cannot address. And what's shown on here on the far left side is questions about the psychometrics, about those surveys, to each individual person's responding to it, and whether they understood the question or not. Some of that we actually will never be able to go back to, because that's very nuanced and it's very hard to capture those. But for everything else, it's the how would a panel of questions belonging to a survey tool need to be captured? What would that look like, and how can that vary between sites? Are there thought processes involved when a patient might have a ICD coded for the presence of a social need, versus each of the records between a question and answer captured within one instance of answering a survey tool? So I will get into all of these in a little bit, but I do want to acknowledge that on the far right side, those questions, which are like design, for sites using Trinetics, for instance, what's the minimum criteria to go from that to extraction and then into OMOP ETL. So a lot of that will be captured in the second paper. Okay, now that said, here's sort of a fairly complicated, but again, very high level thought process for how common data models have to be engineered and what kind of information needs to be captured from the electronic health record. I broke this off into three steps. There's the exploring the flow sheet schema. So for each site, flow sheet records, sometimes people think about nursing flow sheets, but oftentimes they're really just a all-purpose deposition for like each of the questions, or questions would be flow sheet rows, but then to represent all the items that are part of one instance, then it might be flow sheet groups. But I broke this off into like their survey tools, and then there's a relationship between those and all the questions that are members of them. And then each answer option that might come along with it, sometimes these questions are prescriptive and they have certain answer options allowed to them. Other times it might be actually a little bit more open, and there's sometimes multiple answer options that have evolved over time, and so they've gotten included into the survey answers. But for each person who is actually going to respond to the survey, there will be something of a survey question to answer relationship, as well as the time stamping for where they took that question and when it was. So all of that will be important towards knowing the longitudinal steps in when a patient answered at one of these surveys, and really how has that transitioned over time. In the second step, which is triage of flow sheet measurements. So this is where we've kind of acknowledged that each site, the flow sheet questions and flow sheet answers, those might be very specific to that site's implementation of the flow sheet. And even between departments in a single health system, for instance, like Glasgow Coma score or something like that, there could be separate flow sheet instances in order to represent, like, this is how this department has captured this, and then here's another one. So it's not a single one and done, but rather they could be fragmented into separate instances of flow sheet measurements. So whenever that happens, you sort of have to consider, how do you want to map all of them together? What's the appropriate question mapping, as well as what's the appropriate answer mapping? Finally, once you've started an OMOP instance, there's the person records, there's the visit occurrence records. Now you have to sort of combine that along with the bespoke mapping for the flow sheet measurements, and then the timestamping and all those instances from the flow sheet schema, and then create a OMOP observation record for each of those. I do want to point one thing out from this graphic though. In step 3, the script for the ETL logic, sometimes the answers can be like unique, and we wanted to take that into consideration when we were looking at how rare are these occurrences, and are they essentially not aggregatable because of how unique the answers are. So we put a occurrence filter, which is basically just a frequency calculation, and if it's occurring less than 10 times in our entire patient population, probably that's far too specific. And we might want to consider that level of specificity is just not going to be useful in an observational record. But in the whole, this is like step 1, 2, 3, and each step is a lot of mapping together. Here's an example of what the triage for the flow sheet measurements looks like. We're trying to consider what kind of flow sheet measurement and answers are part of this question or record. And also, while we're doing that, we're looking at which social determinant domain this might be related to. So for this example, we were looking at a measurement which is actually asking a person like how long they've been homeless. And this is a quantified number, but then the options actually allocated to this are less than 1 year, 1 to 3 years, or 3 or more years. And we had to sort of look at both that question, how long homeless, is there a appropriate OMOP concept in order to represent this, this flow sheet question, as well as for the answers. So for this one, we sort of categorize that all, any questions related to this are actually in relation to housing insecurity, housing instability, and homelessness. So we did, while doing this, look at the UCSF Siren categories as our frame of reference for what kind of questions might be sorted into a certain specific category of social need or social risk factor. So that's sort of where it comes from. But each entry of this is essentially generated for each unique question. And so we're looking at each question and whether or not all of their answer options are consistent across each other. Then we have to make decisions about the mapping. Now from that, because we were taking into account the timestamp when those responses were made, and also the questions that each respondent had created or responded to, I guess, we could look at something like this, which is what does the historical pattern look like, and what is the present pattern looking like? And we tested this out first at University of Washington, and what we were seeing, this is from November 2019 through March 2020. This is slightly before the beginning of the pandemic. And then November 2020 through March 2021. So we're looking at basically the same time interval before and after COVID had influenced the world. And also, what does that look like in terms of our data collection rate? There's something obviously different about the two images shown here. One is the rate on the left. This is what would be considered maybe our prior rates. We were seeing a lot more data collection about household size, immigration, housing insecurity, and not so much about employment. But when we were looking at employment in the second year of the pandemic, roughly around that January time, February time, that's when a lot of the vaccinations were being deployed. And we could only see this because of the time stamping. But when we were looking at this is also kind of indicating some potential artifacts in the process of transcribing OMOP representation of these electronic health record instances. One thing we did learn from this was that the employment information, sometimes they're just overwriting prior information. And you could think of that like a demographic field. When you have like a change of identity or demographic identity, you potentially just like overwrite that. And so we're potentially not able to see historical employment notations just because of how the electronic health record might have been capturing and erasing or overwriting these things. But there's certainly other factors. The flow sheet records, they should be uniquely time-stamped. So what we're seeing here is the difference between the flow sheet records as well as the like the Epic Way or the our electronic health records representation of occupation and employment. Okay, anyways, so now I'm going to go into the second paper. This is the one that's my keyword is that this is the indirect route in which electronic health record capture of patient level social determinants can go through multiple common data models and then eventually reach OMOP. That earlier figure that we had shown, Dr. Juan Espinoza has really taken upped the ante for how to represent these things. And this high-leveled flow diagram is our 2.0 version. The important factors of this is still that it captures the clinical encounter, the data entry, the primary transformations into the common data model. And then there's a secondary transformation step, which we could probably only see when a consortia like N3C is going to accept the data and then do translations to it. And then eventually we'll see this on the other side, which is the data release. I do want to point out there's these four main components to it. Data and information that's about the clinical encounter and how data is captured. The primary transformation steps, that first step going from the AHR to the common data model, the first one. And then eventually the translation step from common data model to another common data model. And we often just say that this is a harmonization step, but how does harmonization need to work? Finally, the fourth bubble in the bottom left, this is the questions and answers, LOINC code and SNOMED code mappings. This is sort of an integral component where in the data flow 1.0 version, we were really just looking at how it's flowing in one direction. But from putting N3C in the frame, you can see that there's a iterative role, and the mappings can be improved if we're starting to see some things are not mapped correctly. And that actually needs to stretch all the way back to how it would influence the data entry. Okay, so in this paper, we were looking at BMC Thrive, Boston Medical Center's Thrive survey. And the reason we were looking at this is because Thrive and Prepare, these two surveys shown in front, is trying to capture a cross-sectional times, like a snapshot of a patient's social needs. And the screening tool for Thrive is like a single one-pager. What you're seeing in front is in the middle. This is the latest version. And then Prepare is actually like 2-3 pages of questions. So we did want to consider that there's different types of questions captured in each survey. Thrive has its own, and then we also have to consider how the flow sheet records are capturing and representing these question to answer relationships. Oftentimes, this is what it will be called the bespoke mapping. So if we're looking at this is how the screening tool is configured, this is how people are capturing it. And then once we're looking at each of those questions, the question and answer to controlled vocabulary mappings, then we have to actually look at it specific to the flow sheet captures for those. Otherwise, we're likely to potentially miss things or misrepresent what is actually being documented in the flow sheet records. I'll get into the harmonization step and the data collection step in just a little bit, but the completeness is a kind of our end-to-end accounting for how many records are going in and how many records should be coming out in this kind of workflow. So Thrive is this screener. At this site, which BMC basically captures this information into their EHR, and then from the EHR is created an I2B2 instance. From those instances, we sort of need to look at how many of these COVID patients have the instances of interest and how many will be the kind of quote unquote denominator going into the flow sheet extract, transform, load. When we look at the flow sheet records, there's the capture for what is the question, and then what's the unique answer option associated with each question. And so I've separated those into the left and right lanes here. The question actually has to evolve into a controlled vocabulary mapping. And then in I2B2 and Trinetics, they kind of represent that as the vocabulary domain and then the concept code for that question. In contrast to that, the answer options actually can be a little bit more variable, but we're doing essentially the same thing. We're mapping that question, the answer option, to what would be the closest semantic vocabulary for that in the LOINC or SNOMED space. And then eventually the I2B2 Trinetics representation is the vocabulary domain, the concept code for the answer, and then, the vocabulary domain for the answer, concept code for the answer, and then this parentheses with the actual text of what that answer option was. So we're trying to maintain the provenance of it going from EHR to I2B2 Trinetics. And then the next step is from the I2B2 Trinetics to OMOP. These common data models are configured differently. They have different schema, but this is a observation record to observation record. And the in-between is sort of parsing it out and then making sure it's mapping back. Otherwise, we will see things like no matching concept on the other end. To test out what is going in and then what should be retrievable once we're looking at those answer options, we created these concept set. This is specific to the Thrive screening tool and all the question options that are part of it. You'll notice that sometimes the concept names, these are coming from a different research instrument or vocabulary tool. And that's because some of the questions from Thrive actually were sourced from Prepare, or they're sourced from WellRx. And we should be able to see like this flow specific to this survey tool. But for one complete entry with this screening tool, every one of these questions actually need to be captured. And it's just like a panel of questions associated to one instance of data capture. We did a similar thing for the answers. So whether or not the answers were for a specific question was yes or no, we're actually just capturing all the possible variations across the questions in that prior concept set. And then we're making this one bin in order to just refer to the answer options coming out on the other side. And if anything was not mapped, like it ended up as a no matching concept for some reason. If that's the case, then we would have to consider, is there something off with the parsing steps? Or is it that from the upstream end, something was not being encoded into the correct, the agreed upon concept code? And for that reason, we're seeing something flowing downstream that basically ended up outside of the capture. Right. So now that I've gone over the direct route and the indirect route, there are a few things that we wanted to consider when we're looking at the data quality as it reaches N3C. And because there's so many sites part of N3C, we have to consider how can this be done at scale. So a lot of the slides following here are courtesy of Stephanie Phuong from the data ingestion and harmonization team, if you're on the call, thank you so much, because this is like a really good in-depth in understanding how harmonization has to work. There's essentially 6 steps part of this data quality check. The first one is what kind of data is being submitted to N3C. And so this is a native conformance check. The second one is actually that data, once it has been received, it's adequately going to be parsed. So this is going back to that whole vocabulary domain of the question, vocabulary domain of the answer, and then the concept code. And then if there's any provenance information on the other end of that we're actually able to parse any one of those. Otherwise, we might end up with something that is like a concept code with extra spaces for some reason, and it doesn't get transcribed. So parsing is an important second step in this whole process. The third step is actually that once we've considered what the transformation logic should be, it's going from I2B2 trinetics to OMOP. And then between that, we have to do certain parsing step as well as mapping to the controlled vocabulary. That this is actually something that we will apply consistently for all trinetics submitted data types. So this is to say that we're making this parsing and transformation, but it's not specific to just that one site. We're taking that lesson learned from that site and then making a template, so to speak, and then that will be applied to all Trinetic sites. The fourth step is that we're considering the automation. So once we're doing this and we're doing the parsing, translation, and then it'll turn into an OMOPized. It turns into OMOP. But we now still have to consider, did we get what we expect to get downstream? And so this is the data checks, warning tags, and creation of issues to follow up on those instances where data is just not mapped correctly. But you can sort of see that on the left side image, how data gets submitted is site by site. But for each site, there's this transformation step to transform the data from the native common data model to OMOP. And then once that's done and globalization IDs have been applied, then we create this large N3C harmonized data set. And then it sort of goes through like development staging and production. But we still have like data cleaning that might be necessary for this, sort of like a pre-step before all the data is merged together. The sixth step, so this is where data quality assessment really needs to have an end-to-end communication. In this diagram, I'm sort of representing that, data quality from like the conformance of the native common data model to parsing it. Those are just part of the first steps in the primary to secondary transformation. But once we've gone through the creation of templates, the data checks, and then the final checks, right at basically to release, then we've gone through like the first 5 steps. But if there are any issues determined from this, some fixes can be done in the N3C system. So this is like post hoc, but sometimes if you want the data to ever improve, or like there's any acknowledged issues with the mappings, that needs to be returned to the site. And so we have this kind of cyclical process in order to assist with improving the data. This one time through is essentially using BMC Thrive as the case study, but this really can be applied for really any research instrument or combined use of research instruments from a site. I do want to also say that there's like a big plus towards doing this in N3C versus just site by site specifically. And it's that through doing this whole cyclical process, you're essentially improving the data being submitted to N3C and overall improving the maturity of the data and being able to kind of see this one site is capturing data, but how does that contribute towards their research information on each of the patients from those sites? So but in order to sort of understand that, you need to look at a bigger picture of how the site's maturity with social and environmental determinants of health should maybe be factored up. This table is actually from Drs. Neil Barouse, Daniela Meeker, and Juan Espinoza, where they try to break this down according to the 5 domains on the bottom here. And the level 7 up at the top is like the most mature, like a system which really has like this whole workflow and process down, versus certain sites which may actually be more nascent to social determinants of health from patients, and both considering the individual level and the place-based level or place-based information that's taken into account. This graphic is actually a few months behind, but we captured this back in March. But at that time, there was like 14 billion data records in N3C. And I forget how many sites at that time had already been submitting social determinants of health data. But this is sort of like, this is the composite of all the different sites contributing to N3C, whether it was OMOP format or ACT, Trinetics, PCORNet, PSNet, but the aggregate is the N3C released data set that has all these records. But what we are right now is we're trying to consider what data is already in there and that we would pull those back out in order to use those as research features, or features for pre-processing or representation of patient status. The VSAC, the US CDI Value Set Authority Center, they had released these, I guess they're concept sets, but they're concept sets or lists representing the ICD, SNOMED, and kind of concept codes for these different types of social determinants of health domains. USCDI and UCSF Siren, as well as the research instruments, are completely different types of entities. So we do have to consider what is being transcribed into, say, SNOMED, ICD, or SNOMED, and is that really capturing a diagnostic social determinant of health, or is it procedure or goal or intervention? So all of these have been imported into N3C, and they exist as concept sets that can be used to retrieve those records. But what we are interested is combining this for a research question, as well as the kind of information we would have to take into account for a research instrument, like a screening tool. Because screening tools can be captured as LOINC concepts, not necessarily SNOMED or ICD. So if we can combine them, we would probably get a better resolution than just using any one of those by themselves. But there are certain considerations one would have to use or take because of not all the concepts or questions or framing of a question might go downstream into the research data set. Here's sort of an example of where a prepare transportation question, it's like this strange multiple choice option. And if there's a yes, then it's a yes in a certain type of context. But if there's a no, or there's a I choose not to answer, then, what then? How do we want to represent this instance of, they said no, they don't have a transportation issue, but is it specific to each of those medical appointments as well as work-related or lifetime situation transportation? And then separately, if we were going to resolve that, do we have to approach LOINC in order to improve those concepts? Or is there something that we can do in between until the LOINC vocabulary is improved? And we can generate temporary OMOP concepts, a certain vocabulary that's just for capture of that certain concept. And this is the availability of controlled vocabulary. Some vocabulary, some research instruments are just not represented in a controlled vocabulary form. So if we need to, or we're trying to acknowledge that multiple concepts, multiple research instruments are using a same question and same answer representation, but they're not in LOINC or SNOMED, we have at least a road forward to make a temporary controlled vocabulary for it. Okay, a couple of other things that we're also thinking about right now, and this is through social determinants of health data engineering. We still have a lot more to go in terms of the data quality assessment and approaches to do this at scale. But beyond COVID, right? Just looking at infection and the likelihood explained by social determinants of health, risk factors and such, we could consider other questions that are more integral, like transdisciplinary research involving social determinants of health and genetics of patient cases. Do any of those things kind of have a contribution towards likelihood of a medical outcome, or is like genetics influencing the social determinants and then influencing, them together has a overall contribution towards a patient's medical and health disposition? And then we have a lot more questions with regards to machine learning and how to abstract patterns from social determinants of health, whether in an equity perspective or really to consider what are the patterns explained by it. So, and we recently have submitted we got a perspective article accepted looking at social determinants of health and sort of the future of climate change and, COVID what is COVID? COVID is a disaster, but it's a infectious disease disaster. Some of that is that isolated to just COVID, or is it a bigger, broader consideration of risk factors? And would we and should we be looking at bigger, longer term questions with regards to climate change? And finally, just in general, like starting from what is a social determinant factor or research question being asked? Are there additional questions we're not asking right now? And if we were to pursue them, how would we need to consider that with regards to data that is collected or data that still needs to be collected?
Great. Thank you so much, Jim. Appreciate your talk. We have a few questions in the chat. I'll just probably go over them in order. Our first question was, is every site's data used in the conversion process?
If they are available, then that's what we would try to make sure they're getting into the N3C limited data set. That's my short answer, but that's whether the site is submitting it is a different question.
Okay.
And that's where we're really trying to figure out the maturity of each site and what are they trying to, whether they have the clinical encounter to capture the data and then downstream into the data set.
Do you have an idea of how many sites are submitting social determinants of health data? And more specifically, like, do you know how many are primarily using Thrive or the Prepare questionnaires?
Down to the research instrument, I'm not sure about that right now, but some time ago, it was like something of 45 of the 100 something sites. They had some kind of representation of patient social determinants of health. So one thing I didn't describe here was the ICD-10 codes. That's the diagnosis codes for these non-clinical factors. But whether they're used and whether they're used consistently is sort of this data quality question in itself. So there's not a lot of resolution from those because those are just findings. And if they're encoded because of a specific question or an interview, are there other factors also learned about, or were they asked about? We don't really have good resolution on that. So, but Z codes is definitely something that we would use the VSAC concept sets in order to retrieve. But yeah, there's ICD-10 codes have been available for quite some time. HL7 Fire has basically proposed new ICD-10 codes, and we're not really sure when those will get actually implemented by each site. But if those were, how would we need to interpret those? We sort of look at those screening tools in order to see more resolution. But they're a snapshot, so we would want to know if this is the one time they've been captured, they've been asked to the patient, and then we now have documentation of it. Is there some, what's the longitudinal aspect of this, and does it get resolved if it's a social need? I hope that answered it.
Yeah, I'd be curious to see how often sites ask these questions. Are they multiple times, through a health system, or are we capturing it from other systems as well? This next question is a long one.
Sure.
So slide 13, we looked at counts rather than proportions in the pre-COVID and COVID eras. The units on the y-axis were also different. Have you looked at the proportion of patients for whom various types of social determinants of health data have been captured over time?
Yes. So the short answer is the y-axis, the total difference in the scale and axis, that was an important consideration about how quickly can we be capturing these, and whether it's consistent or we're prone to certain convenience biases because it's the health system, and are we essentially getting this from a certain set of patients recurrently and not so much from others. There was a lot of patients which they had acknowledged like social needs. So homelessness and food insecurity, those were like some of the ones which they had the most presence in social need, but they did have a lot of recurrence. So it could be from a certain set of patients where they've said they have these issues before, and their issue doesn't seem to be resolved. So is that simply because of a referral gap, or is there other issues of trying to resolve these the referral is not enough? Maybe it's a bigger, more complicated series of social needs. Now, for a lot of people, there is a question of like, when would people be asked this? Would it be in a waiting room somewhere, and they would just be asked the question before they enter the provider interaction, the visit? Or is it during the visit, and then things are conditional to some concern about housing, and so when that happens, now you ask them the question. So who gets missed and who is being screened is sort of a big variable in the clinical encounter.
I think another challenge has been, sure, we ask the question, do we have the time and resources to be able to actually address it? So there are many things that come up. I know personally in the Prepare tool, when there's questions around income, it creates some tension between the provider and the patient. And I think patients are still getting used to why we're asking such questions. And so both the patient and the provider are still learning.
Yeah, there's stigma, right? Mm-hmm. Associated with social need. And I guess there's also like, when people will acknowledge these things when they're asking for help. Mm-hmm. So if they're asking for help, and then are they getting like meaningful help from that? So there's not really a great way to capture that right now, but a lot of the work from HL7 Fire, I think, is intended to make sure referral systems are end to end. That's not within N3C social determinants of health domain team's abilities, but it's a bigger societal, like entire health system operation type of thing.
Absolutely. Part two, well, we can go back if anything. So another question was, how much of Prepare were you able to map to LOINC, and is the mapping being shared somewhere?
I wonder who's asking that question. So Prepare is it has been incorporated into LOINC. So there is a controlled vocabulary, a LOINC concept code for each question, as well as one for each answer, including the I choose not to answer, that option. So all of Prepare has been mapped into LOINC, and we've mapped that into a screening tool mappings table. It's just like one of the first things we did in 2020 to basically like pursue some of these high yield low-hanging fruit in mapping screening tools. So Prepare is actually already mapped. If you want to get in touch with me, we have those mapping tables. So the Thrive is also mapped. We've mapped, what else is there? WeCare and AHC tools. So all of these types of controlled vocabulary, there's a lot more research instruments out there. We acknowledge that, but Prepare is definitely like Prepare and Thrive were the first two we targeted. May I share screen for one thing?
Sure.
Because this actually feeds very well into what was my last slide. Can you see this?
Yes.
So this as a call to action. So if you are asking questions about social determinants of health and survey instrument screening and mapping, you might want to ask, what's your site's maturity with social determinants of health data? What we can see is from N3C, but me from a certain site, I can ask my own site about the maturity with this type of information. There is sort of a kind of like a 4-step process in this. And one is to ask your site, and you could use the social environmental determinants of health maturity model to do and guide that assessment. If you're looking at any one of those screening tools that we just talked about, Prepare, AHC tools, BMC Thrive, or CUBS, Food Security Survey, Hunger Vital Signs, WellRx, or even the EPIC Social Determinants of Health module, some of these ones have been mapped into controlled vocabulary mappings. And if you know that your site is using those, but then it's not getting into the research instrument, just connect with us, because that's low-hanging fruit. There's definitely some other considerations that most likely only the site manager, the one that manages the OMOP instance, would be able to do the bespoke mapping, right, from flow sheet to OMOP or to the common data model at the site. But if there's not even a process for that, then this is much more fundamental, and we would have to kind of look at that question first. Yeah, if there's any questions about these things or the use of the screening tools or screening tool mapping templates, definitely connect with us.
Thank
But
you.
yeah, that's my shameless plug.
The next question we have is, what tool or platform do you use to automate the process, such as data cleaning, ingesting to data quality checks, etc.?
Okay, so I'll break that question off into 2 parts. One is locally. So how does the engineering work on my site? And then separately, there's how does it work once the data has gotten into N3C? So at my site, SQL Server and SQL Server integration systems. This is really trying to do a lot of things in SQL mappings. So that way we can draw the information from our electronic data warehouse, and then do our necessary quality checks, and then generate those or populate our OMOP observation table. But we have to do this like essentially monthly. So then we need like a pipeline in order to do this. If there's any changes to the mappings, if there's any changes to like vocabulary tables, those sort of need to be housed somewhere and then incorporated into the rest of the mapping. Now, once the data gets into N3C, N3C actually uses Adeptia as the pipelining tool. But a lot of the scripting for parsing and scripting for crosswalk between common data model to common data model, those are publicly available in the N3C CD2H data ingestion and harmonization pipeline. I'm sorry, data ingestion and harmonization GitHub. So there are scripts, and I forget what language of SQL they're written in. It might be Postgres or MySQL, but essentially they're like there is open source scripting and sort of a general structure that can explain how it was done in N3C. I think some of it might also be Python. So it's not all, I mean, any one of these pipelines generally can speak multiple languages. So it can work how you can adapt it. I hope that answered the question.
Wonderful, thank you. I'll give everyone else a moment in case there are any other questions.
So yeah, this is a great talk. Very, very, very interesting and very useful. A couple of questions. Um, one is, what fraction, just kind of roughly, of the N3C data from all the sites actually has, what you consider, useful um, SDOH question response data?
Mhm. What fraction? I haven't updated my.
50%, just as a gut feeling. Um, is it relatively rare to have that information, or is it fairly common?
I think this can be explained a little bit by the literature surrounding what's the rate by a certain health system. So Z codes have basically been the most conventionally used structured representation. And then other than that, it would be clinical notes. And then flow sheet records, these screening tools. So some sites, if they have it as an operational workflow, then it would be captured that way. But since some sites use Epic, so Epic Social Determinants of Health module is now more available. It's just a question of, are they implementing it? So we can't really fill all those gaps. But I remembered a paper by, it was like 2019, and then there was another paper published in 2020 by Dr. Elham Hatef at Johns Hopkins. I think the rates that she had reported in there was like, there's something like 4 to 10% of all patients had any social determinants available to them, whether it was in clinical notes or in the structured information. But that's at the beginning of the pandemic. And we've definitely seen that with more availability of these tools, and also a stronger focus on non-clinical factors, that there's more initiative towards understanding what's keeping patients healthy. I don't think that we'll just see Z codes moving forward. There'll be more like contextual information associated either to the NLP extraction or structured screener tools. So
no, but one of the, just one specific, and just your gut feeling. Say we take food insecurity, and obviously, if you have people who are labeled as having that, then you know that. But obviously, you need the denominator. So you need to say, okay, for how many sites is this question answered frequently enough that you could actually use that as a social determinant of health? And just in terms of potential scientific users of N3C, sort of a sense as to what might be actually available. Obviously, if it's not sent, if it's not uploaded, you don't have it. But
yeah, we'll see a gap. So I don't have an estimate number, but I can give you my general approach to figuring out that number. We know that different health systems have like payment methods associated with them. Some safety net hospitals basically receive mostly Medicare patients, and state by state, there's some variation in like what is being reimbursed for screening. So Medicare and Medicaid definitely does endorse AHC tools, and potentially that's one reason why more sites, more patients have that type of data available, maybe as opposed to say Prepare or BMC Thrive. But I mentioned that Prepare is like 3 pages, BMC Thrive is 1 page, AHC Tools is like 7 pages. That's a lot of questions. So there's a sort of a question of how often do they have to do this? And also, is this specific to a site's kind of mode of business and reimbursement? Certainly, if they do have that reimbursement, we'll see data downstream. And so that's sort of a generally good thing. But if there's not, it's just because we just don't, they're not as mature with the extract transform load process, or they just don't have that clinical encounter workflow. So we don't know those questions, but we certainly want to not take a single observation record for face value, but rather be able to calculate the whole denominator of screening. As it is right now, we could probably use the questions, and I only showed the BMC Thrive question and answer concept set, but there's actually like a concept set for housing instability, one for food insecurity, one for like employment and occupation. And if any of those information are available, they could be retrieved from the N3C limited data set. So more to come.
Great. Well, thank you.
Yeah. Okay.
All right. Well, thank you again, Jim, for a wonderful talk, and we will see everyone next week.
Thanks for having me. Have
Thank
a good
you.
one, everyone.